Hey guys, so I'm back and starting in on myocardial ischemia. Alright, so normally the coronary arteries supply blood to the heart muscle, which pulls oxygen out very efficiently. That's how it normally works. Now, pathophysiology speaking, in myocardial ischemia, there is a decreased flow or decreased oxygen content that is insufficient to meet the metabolic demands of myocardial cells. So, like with most of this, it's a decreased blood flow, decreased oxygen, all that kind of fun stuff. So, this anaerobic, lack of oxygen, metabolism leads to tissue hypoxia or low oxygen, which leads to chest pain or angina pectoris, which we'll talk about next. Myocardial ischemia will develop within 10 seconds of occlusion. Big deal. So, cardiac cells are only viable for 20 minutes after ischemia starts. And then if blood flow is not, like if it's restored within 20 minutes, you're usually okay. But if you don't restore blood flow within 20 minutes of myocardial ischemia, a myocardial infarction will occur, which we'll talk about after this. So chronic ischemia may result in an impaired left ventricular functioning. Now, remember when we're talking about the heart, the left ventricle is the last step before oxygenated blood gets pushed up through the aortic valve, into the aorta, and to the rest of the system. So that's where you're usually going to have a lot of your issues, and we'll talk about that more in heart failure. So some of the things you're going to see is a fast heart rate or an S3 gallop, and then it may be diagnosed through ECG or EKG stress testing. And then the changes you're going to see with that is you're going to see either an ST depression or an elevation or a T-wave inversion. And then the way to treat myocardial ischemia is going to be either a PCI or an angioplasty or a CABG. And no, I do not know what either one of those are. I do believe that CABG is a coronary artery bypass graft. But go ahead and look it up. Okay, so moving on to angina pectoris. So this is chest pain. This is what myocardial ischemia causes, which I want to say is a symptom then possibly of a myocardial infarction. That's at least how I'm remembering it. So angina pectoris occurs when there's a deficit of oxygen. Again, remember what we talked about with myocardial ischemia. Deficit of oxygen to meet myocardial needs. So angina pectoris is the same as chest pain. It is caused by myocardial ischemia. Now, I'm only going to focus on two types of angina. I know there are about 5 or 6. But I'm going to focus on stable and unstable because that's what she said in class. So stable anginas are transient, which means they're short. They don't last that long. And they usually last only about 3 to 5 minutes. And somebody with a stable angina is going to describe the pain as clenching or radiating. All right, so stable angina will occur because of an inability of hardened arteries to dilate in response to an increased demand. So kind of to do a little bit of a connection. So if you're dealing with your hardened arteries, this kind of goes back to your arteriosclerosis and your atherosclerosis. And jumping ahead, myocardial infarction, one of the most common causes is atherosclerosis. So with angina pectoris, you are having chest pain due to atherosclerosis or atherotic-like symptoms. That's how I connected it. Okay, so that's stable angina, and then unstable angina is also known as reversible myocardial ischemia. However, unstable angina is warning you that a myocardial infarction is imminent. So it can be reversed, and you won't have that myocardial infarction, but it is warning you that an MI is about to hit, basically. So it's also known as a new angina, which either occurs at rest or increases in severity and frequency. And angina pectoris, in and of itself, it can be triggered by physical or emotional stress. So we're likely to have anginas in nursing school because of emotional stress. And the attacks, as the disease progresses, the attacks are going to become more frequent, they're going to occur more often, and they're going to be a longer duration. So it's not going to be this transient 3 to 5 minutes crap, it's going to be longer. And then it may be relieved by rest and coronary vasodilators. I would know this, such as nitroglycerin. So nitroglycerin for chest pain, nitroglycerin for angina pectoris. This is why a lot of people that are having, believe in MI, get nitroglycerin, just to keep in mind. Okay, so that's angina pectoris. Moving on to myocardial infarction or a heart attack. So a myocardial infarction occurs when a coronary artery is totally obstructed. The most common cause, like I said, is atherosclerosis. And what you need to determine, in order to determine the damage from a myocardial infarction, you need to know its size and its location, the size of the occlusion. So the diagnostic test for myocardial infarction, I'm going to go through this rather fast. Again, like I've said, serum enzymes, leukocytosis, arterial blood gases, pulmonary artery pressure measurements may be helpful, and serum myosin. And there's a couple other ones, but go ahead and review your notes. For treatment, these again are quite a bit, but some of them should be common sense. So the one I didn't understand is tissue plasminogen activator. I don't understand what that is. But then you have cardiac rehab. So, rehabilitation for the heart to, help fix myocardial infarction. Reduce the cardiac demand. That makes sense. You're going to want to do some oxygen therapy because, again, we have reduced oxygen going through the body. Analgesics to take away the pain. And then some anticoagulants to prevent any kind of clotting, and thrombolytic agents again. So if you're taking any medications while having an MI, those medications are going to be used to treat the dysrhythmias, hypertension, and congestive heart failure, which could be coupled with an MI. And then possible complications. These I would say are pretty important to know. Sudden death. Kind of big. And then you have cardiac tamponade. Go ahead and look that up. I looked it up recently, but I want to say it's like an obstruction or fluid in between the walls by the heart. Go ahead and look it up. But that's, I think, what I found when I looked it up. Cardiogenic shock, so we'll get into that more in shock in a minute. Cerebrovascular accident, also known as CVA, also known as a stroke. And congestive heart failure. Okay, so speaking of heart failure, that's what we're moving on to. So during heart failure, the heart is unable to pump out sufficient blood to meet metabolic demands of the body. So it is usually a complication of another cardiopulmonary condition, so it's not usually a primary thing, it's a complication. And good thing to note, kind of how I was talking about earlier, is heart failure usually originates in the left ventricle. Again, this is the last step in the heart before it goes up through the aortic valve into the aorta to the rest of the body. That's when it's been oxygenated, it's ready to go. If you have an issue in that portion of your heart, we've got problems because it's not going to be able to push the blood out that has been, oxygenated to get through the rest of your body, and that's going to cause a lot of issues. So we've got two different types, left-sided and right-sided heart failure. We'll start in on left-sided. So in left-sided heart failure, the blood will eventually back up into the pulmonary system. So if you think about how the heart works, like I said, the left side, the blood's already been oxygenated. It's gone through the pulmonary system. So once it goes through the pulmonary system, it comes down into the left atrium and then goes through, goes through the valve. I don't want to say which one it is because I don't remember. But it goes through the valve and it goes into the left ventricle, which then goes to the rest of the body. So in left-sided heart failure, your left ventricle has weakened. It has weakened. It doesn't have the necessary ability to pump through that aortic valve into the aorta to the rest of the body. So because of that, it's going to cause a backflow, and that backflow is going to go right back up into the pulmonary system. So we're talking fluid and stuff in your lungs, in that, that type of area, which is where you end up having issues breathing, you're coughing, you're exhausted, because it's all backed up into your pulmonary system. So yeah, it results in elevated pressure and congestion in the pulmonary veins and capillaries. And so your symptoms, like I said, they're going to include fatigue, activity intolerance, shortness of breath, coughing, orthopnea. Now, orthopnea is when you can't really breathe when you're lying down. So somebody with heart failure, left-sided specifically, but somebody with heart failure, you're going to have to put them in an incline, whether it's at 45 degrees or 90 degrees. They're not going to be able to lay down and be able to breathe. They're going to have to be sitting up. And then we have paroxysmal nocturnal dyspnea. Now that means you're having like intermittent episodes of shortness of breath and difficulty breathing at night. Nocturnal dyspnea. And then lastly, a big thing to keep in mind for left-sided heart failure is this is where you might have your confusion. So the reason why you're going to have confusion is because of the fact that if your left ventricle is not working, it's not pumping oxygenated blood throughout the body, that means oxygen is not going to your brain. So if you don't have oxygen in your brain, one of the first signs of serious issues is going to be like confusion. Level of consciousness is going to change, that kind of thing. So, okay, that's left-sided. So moving on to right-sided. Right-sided heart failure is characterized by an impairment of pumping ability on the right side of the heart. No duh. And this is where the blood is going to back up into the body. So if you have, this is where your right ventricle is weakened. So your blood normally comes through your superior and inferior vena cava, and it goes into your right atrium, and then that goes through into your right ventricle. So if you have an issue with your right ventricle is in charge of pushing the blood up through the pulmonic valve into the pulmonary system to get oxygenated before it goes to the left side and goes to the rest of the body. So if your right ventricle can't get it up to the lungs, you end up having a backflow into the rest of the system. So this is where you're going to see edema. This is where you're going to see abdominal discomfort, bloating, fluid back up in the rest of your body because of the fact that the right ventricle can't do its job. So yeah, congestion, elevated pressure in the systemic veins and capillaries. The most common cause is a left-sided dysfunction. So based on looking at the signs and symptoms and based on knowing, anatomy and physiology, I'd say a left-sided heart failure is probably worse, but that's just my assumption. And you've got to think the left side is the thing that pushes it to the rest of the body, pushes oxygen and nutrients and everything that's supposed to go to the rest of the body. If you have an issue with the left side, that means if it's just, let's just say it's pushing out a little bit at a time, then your right side's not going to be able to function correctly. And I mean, it is kind of a symbiotic relationship. They're both gonna, if one thing goes wrong with the other one's gonna have a problem, that kind of thing. But specifically left side, because I would say that's the most important. So this is where you're gonna see symptoms resulting from the volume overload, so that pooling and everything of fluid throughout the body. So it's gonna lead to ascites and edema, and then patients may complain, like I said, of abnormal like bloating and discomfort. They may have a poor appetite, also may have nausea and vomiting. And then, okay, so in severe cases, this can lead to distended neck veins and cerebral edema. So the way that I was kind of able to figure out why that is based on gravity, the first signs are going to be in your lower system. So your legs, having edema in your legs and everything like that. You've got to think that your neck veins and your brain are above the level of your heart. So it's fighting against gravity. So in severe cases, when that pressure and that congestion is so built up, then it's going to progress upwards. So I would say it's at a worse stage when it's coming up here. Okay, so that's heart failure. So the last part of this chapter is shock. So I've broken this down pretty severely, so again, look at your notes. But if we have a couple different types. So if we're dealing with hypovolemic shock, you have an issue with your blood volume. It's low blood volume. If we're talking about cardiogenic shock, there's an issue with your cardiac output, which cardiac output. And then you have vasogenic, which at least in the notes actually has vasogenic and then parentheses neurogenic / and distributive parentheses. So those three kind of go together. Good way to remember it because I know there's a really big list. And then you have anaphylactic and septic. So the vasogenic and the anaphylactic and septic, you have an issue with your peripheral resistance. There's a lot of vasodilation going on in this entire group of vasogenic, neurogenic, distributive, septic, and anaphylactic. That's peripheral resistance, vasodilation, all that kind of fun stuff. So, quick thing before we go into specifics, we have our common pathways for shock, and these are going to be three different things. Either a decreased cardiac output, a impaired cellular metabolism, or a decreased tissue perfusion. Okay, so moving on to the specific causes for each type of shock. For hypovolemic, you're losing volume. So it's pretty basic. If you're hemorrhaging, burns, dehydration, and then the two that kind of are out there, and I have to do a little bit more research on them, are your peritonitis and your pancreatitis fall under things that could cause hypovolemic shock. All right, so cardiogenic shock, basically anything to do with the heart, and technically also kind of the lungs. But if you have a myocardial infarction of the left ventricle, cardiac arrhythmia, pulmonary embolus, and cardiac tamponade again. And then, so for vasogenic or neurogenic distributive shock, this is where it's going to be if somebody's in pain, if they're like terrified, if you have a spinal cord injury, also if you have hypoglycemia due to like an insulin shock. This is where you're going to see your vasogenic shock. All right, so for anaphylactic shock, we went over this in the last test. This is your allergic reaction. So drugs, shellfish, nuts, insect stings, all those big, normal things that people can suffer a really bad allergic reaction to. And then lastly, we have our septic shock. This is from virulent microorganisms, usually gram-negative, or multiple infections. Okay, so last little bit, our signs of shock. I came up with some stupid acronyms for these. I apologize, but if they help you, great. If they don't, just, memorize the signs. My acronym came out to STOP SAL. So STOP, S-A-L. It's syncope, tachycardia, oliguria, pallor or paleness, sweating, anxiety, and lightheadedness. Those are my signs of shock, and they're usually the initial signs of shock, so the onset. And then you're going to have some shock compensation, like what your body's going to do to compensate for when you go into shock. And this came out to SARAS, without the H, so S-A-R-A-S. This is when you're going to have your SNS and your adrenal medulla are going to be stimulated. Your ADH is going to be increased. Your renin is going to be increased. You're going to be in an acidotic situation, so that acidosis is going to stimulate your respiration. So again, going back to the first test, breathing off the oxygen, breathing off the CO2 in order to bring your body back to homeostasis. And then lastly, steroids or glucocorticoids are going to be secreted in your body. Keep in mind that glucocorticoids are anti-inflammatories. All right, lastly, we have 4 specific complications of shock that I decided to choose from. And it came out to SSPD, so I kind of thought of, since you have to stop SAL for the signs of shock, and then your shock compensation is SARAS, SSPD, SARAS Police Department, has to stop SAL. That's how I came up with it. So septicemia, shock lung, which shock lung is also adult respiratory distress syndrome, and then paralytic ileus. So I believe when I looked it up, paralytic ileus is like an issue with your intestines being able to, like your peristalsis is not working correctly, so things move. It's not moving through your gut like it's supposed to. And then DIC. So again, your we'll get into this. Oh no, we already covered that in hemolytic, but your disseminated intravascular coagulation is another complication of shock. So remember when we talked about DIC, it's normally a secondary complication to another condition. So keep that in mind. And that is everything I have for cardio. Again, I will do another video that is cardiac output and on EKGs. And then I might also include like the basic anatomy of the heart and how the heart works, just for a quick review for anatomy for you guys. But other than that, that is it for cardio. Thank you for watching.